And we'll make a start. So first of all, just to introduce myself, I'm Chris Graham. I'm the Chief Executive here at Picker. For those of you who aren't familiar with Picker or passingly familiar, we're a charity. We're based in Oxford in the UK, hence my lovely background. Um, and our vision is of the highest quality person-centered care for all, always. We work to promote the idea that people should be active, involved partners in their care rather than the passive recipients of it. And we do that in no small part through understanding, measuring, and improving people's experiences. We're very well known for the work that we do around large-scale national surveys, and today we're going to be talking about some of the evidence that we've accumulated over the last year and a half or so, and what that tells us about the current state of person-centered care in the National Health Service in England. Our fundamental ethos has always been that patient experience is a measure of the quality of person-centeredness. And if that what we aspire to in health services is an approach that is centered around people and their needs and preferences, then listening to their experiences and hearing their voices tells us how well we're achieving that. So that's what we're going to be talking about today. What I would like to just ask you to do whilst I'm going through the agenda and the housekeeping is please take the opportunity to introduce yourself in the chat. You should have access to the chat. You can just write a few words about yourself, about your name, your organisation, where you're from, what you're hoping to get out of this session. There's no obligation, but it's always nice to put some names to the screens. In terms of the agenda for today, I'm going to be giving a brief kind of introduction, and then I'm going to be handing over to my colleagues to do all of the detail. So joining me today, I have Molly Hobson, who's a senior research associate at Picker. I have Tom Stocks, another senior research associate at Picker. Ollie Potter, our policy and public affairs manager. And we're also very, very happy to have Maria Bracey joining us from Royal Devon University Healthcare NHS Foundation Trust. Maria is the Macmillan clinical lead for the organisation and is going to be describing a case study based on one of the projects that won an award at our Picker Experience Network Awards in 2025. So through our agenda, we're going to start with a description of the methodology for this project, how we use the data that we have to look at the quality of people's experiences and person-centeredness. Then we're going to talk through the key findings. We have that case study, and then we're going to have some time at the end for Q&A. I'll talk a bit more about Q&A in a second. As I say, because we're using the Teams webinar function, we have two separate chat dialogues. There's the standard chat, which everyone's familiar with, where you can talk to participants and each other. There's also a Q&A box, and that's really useful for us because it helps us queue up questions and then make sure that we're answering them. So if you want to ask any questions for any of our speakers, please do add them throughout the meeting. Add them in through that Q&A box if you can. It just makes it easier for us to keep track of them. And you can also upvote questions from other attendees too, if there's something that you particularly want to see answered there. I need to tell you that we're recording the webinar. So if at any point you come off mute and come on the mic, you'll be recorded as part of that. So just bear that in mind. We will be sharing the webinar via our website for anyone who wasn't able to attend live. We'll also be sharing the slides to you via email in the coming days. I don't think there's anyone who's mentioned any accessibility requirements. If you do have any issues, do give us a note in the chat. But if you need captions, we do have a live transcript on. You can go to the more button at the top of your screen, go into language and speech and show live captions. It may struggle with my accent, but it will do its very best to try and replicate what I'm saying. And we're not expecting any fire alarms, so I can move on from the housekeeping straight into the welcome and context. I just want to say a little bit of background about this, especially for anyone who's joining us from outside the NHS in England, because this work is informed by the contemporary policy context in the UK and also by the kind of history of measurement in the UK. We are fortunate that in the NHS in England, we have a large-scale measurement program that collects a lot of data about people's experiences of care. And that aligns to the national policy context, which has seen a bit of a renaissance of interest in patient experience and person-centeredness over the last 18 months or so. After the new government came in the summer of 2024, they commissioned an independent investigation into the NHS by Professor Lord Aradarzi, and then began work on a 10-year plan for the future of the health service. Both were very, very clear that, in Darzi's words, the patient voice is not loud enough, and that patient experience needs to be prioritised to improve person-centeredness. That was then echoed in the Dash review, Penny Dash's review of the patient safety landscape, which argued that experience and effectiveness, two of the three components of quality in the NHS, have received relatively less attention than the third component, patient safety. And that work was needed to rebalance that and reconfigure the attention. At the same time, some of the structures that support patient voice have been threatened by recent changes. So Healthwatch England and its local branches are now due to close. They are statutory bodies that represent the interests of patients. So whilst the Secretary of State, Wes Streeting, has been very, very clear that the first principle for change in the NHS is that the patient is king, there are threats to how that happens. And so we feel like we're at an inflection point, and that's why we wanted to look at the state of person-centered care today. How have we done that? We have taken data from a collection of surveys that were involved in managing for the Care Quality Commission and NHS England. We've gathered together data from patients and staff, and we've used that to look at experiences arranged against PICA's principles of person-centered care, or principles of person-centered care, an evidence-based framework of the things that matter most to most people when they use services. And what we found is good overall experiences. People were positive in some ways, but also concerns about waiting times. And that echoes findings from other collections like the British Social Attitudes Survey. Whilst there was good confidence in interactions with individual staff, there are problems with continuity of care and smooth transitions, which is somewhat contrary to the policy aspirations for coordination of care. There's also variation in the level of holistic advice that has implications for the left shift that the government's talked about from hospital to communities. Similarly, we talk about people being partners in care, but often there's room for improvement in how people are involved, even though they feel treated with respect one-to-one, and not always given the opportunity to use their expertise and their knowledge. And the same goes for the involvement of families and carers. We're going to unpack all these findings a little bit more, so I don't want to get into too much depth now, but that's just a kind of introduction to some of the key messages that we're going to be going through. I'm going to hand over now to my colleague Molly Hobson, who's going to start to take us through the findings in a bit more detail. I think Molly now has control of the slides, so without further ado, over to you, Molly.
Great, thank
you. You've got on mute, Molly.
The joys of technology. I pressed my space bar and I thought it'd move my slide. Thank you. Okie doke. So it's great to see everybody today, and it's great to see everybody introducing themselves in the chat. So welcome. So, as Chris has already touched on, to understand our methodology for this report, it's necessary first to understand what we mean by person-centred care. So as an organisation, PICA have developed a set of principles for person-centred care. Now, these have been developed over years of original research with patients, with families and with staff. And like Chris said, they identify what matters most to people in regards to care and the care that they want to receive. So this goes beyond clinical safety and focuses really on the human elements of care. So how care meets individual needs, how it kind of takes into account preferences and encourages individuals to take active roles in their care. So for us, it's more than a framework. They're the foundation for how we understand and how we measure and how we improve care. So the 8 PICA principles we use as our pillars for understanding and exploring the state of person-centred care. I'll give it 1 second. So some of these principles can be seen on the screen. So fast access to reliable health advice, effective treatment, continuity of care, and we'll go on to talk about these a little bit more in a moment. So the methodology used for this report centred on reviewing data collected through 9 national surveys. So these surveys are collected on behalf of CQC and NHS England, and these surveys capture a variety of insights from staff, from patients, from children and young people. And across all the surveys, we asked nearly 900 questions. So within that, we actually had nearly 1 million responses, or over 1 million responses. So we had 232,000 responses from patients and nearly 800,000 from NHS staff. These surveys were coordinated across 2024 and 2025 and published between November 24 and November 25. So in order to examine the state of person-centred care, it was necessary then to refine the questions from across all of those surveys into those that best reflect the state of person-centred care. So to refine the questions from the surveys, we first used AI to do the initial map of each question to a pick a principle. So this was largely based on a keyword search. 2 researchers then reviewed and refined the list to both ensure accuracy and remove any questions that were felt to be unrelated. And then as we were going through QA-ing, researchers also began to identify sub-themes that sat within each of those primary 8 principles that we've just spoken about. The research team then mapped approximately 15% of the questions to the sub-themes, and we then went about writing clear definitions for each of the sub-themes and used AI one final time to map the remaining questions to those sub-themes. So we had the kind of overarching picker principles and then the subcategories within those picker principles. This final mapping was then again reviewed and QA'd by a researcher, and the results, and it resulted in a really clear set of questions that sat within each of the picker principles. Now, given the scale of data held, as I've mentioned, there was nearly 900 questions. The research team had to use their judgment to report on the stats that best reflected the principles, that best illustrated strengths and areas for improvement, and related most directly to the current policy context. I'll now hand over to Tom, who can talk about what some of these findings look like.
Great, thank you. Hi everyone, I'm Tom. I'm a Senior Research Associate at Picker. I'm going to be talking to you a little bit today about quality of care, and then I'm going to hand over to my colleague Ollie, who's going to take you through the rest of the key findings. So, quality of care sits at the top of the results section of the report, and as you might expect, is woven throughout the report as a theme. But it works really well to demonstrate the concept of what we were trying to do by bringing together the different sources of insight we have to paint a picture, to show what's happening across the system. So on the slide at the moment, we've got a chart showing results from 6 of the surveys that we were looking at, that each asked people to rate their overall care quality on a scale of 0 to 10. And we've taken the response options 8, 9, and 10 to be a positive response. And what we can see here is variation in how people are responding to that question, depending on which area of health and care you're looking at. So you can see for community mental health, around 48% of people said that their overall care quality was positive. Whereas if we look at cancer care, so the bottom 2 bars here, you can see that around 90% of people said that their care was positive. And as we've done for the other areas and the other sub-themes under each of the picker principles through the report, we've also brought in relevant but different insight from other surveys. So the maternity survey, for example, says 37% of respondents had considered making a complaint about that care. And in the children and young people survey, we can see that 73% of young people felt they were very well looked after in hospital. We've also got some data from the staff surveys. So 64% of substantive staff agree or strongly agree that they'd recommend their place of work to a family or friend, and that's 67% for bank workers. So the approach I've outlined here about quality of care reflects what we've done across the report. And then alongside the survey evidence that we're talking about, the report also includes vignettes from the Picker Experience Network Award winners. And these are awards that recognise best practice in patient experience. And that's to celebrate the work of those organisations and to highlight the work that's being done to improve patient experience. And then we've also included examples of where we've used data to influence policy change through consultations and other outputs. So I'm going to pass over to my colleague, Ollie, who's going to take you through the rest of the findings from the report.
Thanks, Tom. So hi everyone, thank you for joining us this morning. My name's Ollie and I'm the Policy and Public Affairs Manager here at PICA. So I am going to take us through some of the key findings in the report in a little bit more detail. So Chris has touched on waiting times as a concern for the first principle, which is fast access to reliable healthcare advice. While over half of inpatients said they waited more than 6 hours to be admitted to a ward, 18% said that they waited more than 12 hours and 10% said they waited more than 24 hours. Access to help when needed is also relatively mixed. So 73% of respondents to the under 16 cancer patient experience survey said that they were always able to get help when they needed it. But this is compared to 64% of people using maternity services during labour and birth, and this reduces down to 54% when they are asked about their experience after birth. So you can see there's a variety of experiences, both within pathways and across different pathways as well. Moving on to the second principle, so effective treatment by trusted professionals. So we've talked about general confidence in staff, which is overall quite high. So for inpatient care, for example, 80% of respondents said they always had confidence in the doctors providing care to them, and this was 78% for nurses providing that care. And in children's cancer care, the number was also quite high. 83% said that they always had confidence and trust in staff. Again, we do see some variance in the maternity survey in particular. So we can see, because there are various questions across the survey that track different parts of the maternity pathway. So during labour, 77% of people said that they felt confident in staff, but this reduces down to 69% when they're asked about the care they received when they returned home. Looking at continuity of care and smooth transitions. So there are really positive results in this section. 90% of cancer care patients in adult cancer care felt that there was high collaboration among staff. But when we look at other areas of care, this reduces down. So it's less positive in maternity care, where 74% of people said they were confident in staff, and down to 73% for children and young people. We can see that staff are also less positive still themselves. So the NHS staff survey of substantive NHS staff, only 54% of staff say their team works well together to achieve their objectives. Then if we look at clear information, communication and support for self-care. So again, some really positive results here. 91% of adults and 90% of under 16s accessing cancer care were positive about having a main point of contact for their care. Similarly high in the children and young people survey, where 90% said that they had a main contact person. When we look at community mental health, the results are poorer. So 78% said they had an out-of-hours contact for crisis care, and only 74% of inpatients said they had a contact to reach if they had any concerns after they'd left the hospital. We can get a sense from the NHS staff survey about why some of this might be so. So only 27% of staff said they rarely or never have unrealistic time pressures when they're at work. If we move on to the next 4 of our 8 principles, so we've got emotional support and empathy and respect. So in terms of the key findings for this principle, patients feel they are treated, for the most part, with dignity and respect. And there's quite high numbers, particularly in maternity care, around 87% they were always treated with dignity and respect. But this does reduce when they were asked about the kindness that understanding they received after the birth of their child in hospital. So there is some variation across the maternity pathway. We can also again see that the results are poorer in the community mental health survey. So only 65% said that they were always treated with care and compassion in those services. The next 2 are around the involvement of patients. So that's the dark blue box, and the purple box in the bottom left-hand corner is around the involvement of carers and families. So we'll look at the patient involvement aspect first. So variation in involvement in decisions is relatively high in maternity care, except for the decision to be induced, where only 59% of respondents said that they were involved in this decision. This increases up to 80% in other parts of the maternity care pathway. The results are quite low in urgent and emergency care and also in inpatient settings. And then again, we're seeing that they're quite low in the community mental health services, with only 29% of respondents saying they feel in control of their own care. The results are really positive for maternity care when it comes to the involvement of family and carers and partners in decisions and in their care. So 94% of people accessing maternity care and 85% of adult cancer care patients said their family and carers were involved as much as they wanted. But again, this reduces in community mental health care and in UEC care. So only 45% of community mental health service users agreed that their family were involved as much as they'd like. And in urgent and emergency care, we can see that there's a split between the different types of services. So in urgent treatment centres, it's slightly higher at 66%, and it's slightly lower at 54% in A&E. The final principle is attention to physical and environmental needs. So we can see there's a poor perception of privacy when checking into urgent and emergency care services. So only 51% of respondents said they definitely had enough privacy when checking in at an urgent treatment centre, and only 49% said so in A&E. We also see concerns from both staff and patients when it comes to the access of food and drink when they are in a healthcare setting. So we can see that 44% of people in A&E said they could definitely access food, while the CYP survey notes room for improvement as well, with 49% of parents saying that there was always enough food available to them when their child was in hospital. Only 27% of respondents to this survey said that access to food is very good. And we can see on the staff side that only 22% of substantive staff responding to the NHS staff survey said they always have access to nutritious and affordable food while working. What I'm going to do now is I'm going to take us through the recommendations that are included in our report. And what we've done is we included 3 different groupings for these sets of recommendations. So we have 2 boxes on the left-hand side, so the purple and the light blue. These are kind of broader recommendations that are focused around listening to and acting on patient voice, and then embedding person-centered care. Those on the right-hand side in the dark blue box are more focused around the key findings in this report, and they kind of are very specific around some of the information that we covered in the last couple of slides. So I'll go through the recommendations quickly, and then I'll hand over to Maria to give us a sense of her winning project at the PEN Awards in 2025. In terms of listening to and acting on the patient voice, so we've got 2 recommendations here. One is around appropriate measures to support those at risk of digital exclusion, and that's because there's a wholesale shift from analog to digital as part of the NHS 10-year plan for England, and we would like to make sure that those that are not digitally mobile and digitally able to use these tools, or may not want to use these tools, are not at risk of digital exclusion, which could exacerbate existing health inequalities. We're also very keen, and we've mentioned this already as part of the presentation, to safeguard an independent patient voice in some form in the health service. And that's in response to the recommendation around the abolition of Health Watch England. Then moving into that middle box, so we've got a couple of recommendations here. 4 around empowering organisations to understand and act on the feedback that they receive from both staff and patients. This is really important because if we are collecting this data from staff and patients, we need to be able to demonstrate change as part of that. Linked to this as well is training NHS staff in person-centred care to ensure they have a solid grounding in the principles of person-centred care. Then looking at the 10-year plan again, so that committed to a Directorate of Patient Experience at the Department of Health and Social Care. This is a great step forward. We're really pleased to see that in the 10-year plan, but we would like to see an update on how this has progressed since the plan was published. Then we recently published, before Christmas, a report on the reform of the NHS Friends and Family Test. And as part of that, we touched on the elective reform plan for patients that was published in England last January. As part of that, there was a recommendation that trusts should have a patient experience champion on their boards. We would like this role to be reassessed in 2028, which means it's 3 years after the publication of that plan. And we would like to see directors of experience introduced at NHS organisations, and they can work closely with the newly formed Directorate of Patient Experience in DHSC. Then finally, in terms of filling the gaps identified in 2025, so for us, one of the most important ones here is filling the current gap in patient experience of waiting for care. So at the minute, we don't have a clear picture of people's experience when they're actually waiting for care. We only collect that after the fact when they have received their care. We'd also like to see some strategies developed around waiting well and support for self-management and peer support. As we touched on in the presentation, family and carer involvement, we would like to see greater strategy around that. And all of these strategies should be designed in collaboration with patients, service users and their families and carers. Healthy, nutritious food. Obviously, we touched on that in the last principle there. That's not just for patients, but also for staff. And then in terms of digital amenities, there are some findings in the report around access to Wi-Fi that are covered in some of the national surveys that we run, and demonstrates that there is a lack of digital amenities within healthcare settings. And obviously in the context of the shift from analog to digital, this can be used as kind of a quasi point of seeing how digital development is happening in the health service. And then finally, there were quite a few findings within the report around urgent and emergency care. And so we felt it would be appropriate to develop a separate strategy for patient experience in emergency and urgent care, as there are a number of areas to be considered as part of that. Now, before I hand over to Maria, just in terms of looking forward and something for you to think about for the Q&A, we'd like to know if there's anything you'd like to see included in the state of future person-centered care. It's a report that we would like to run in the future again, and it'd be great if you had any suggestions for things that could be included in a future iteration. Things that we've considered from our side could be looking at longitudinal data from various surveys, but also looking at subgroup analysis, particularly around protected characteristics and different experiences for different groups. What I'm going to do now is I'm going to hand over to Maria, who's going to take us through her project that won at our PEN Awards in 2025.
Okay, so good morning. My name's Maria Bracey. I am the Macmillan Clinical Lead here at the Royal Devon and Exeter Hospital for Personalised Care and Support. And we were lucky enough to be winners in the Cancer Patient Experience of Care for PENA last year in October. I'd like to just share our little project with you, which was very patient-centred. We had a very simple ambition for our project, and that was to develop a single point, personalised, digitalised end of treatment summary. So end of treatment summaries are one of the 4 components of cancer personalised care and support. We wanted to work that across 2 hospital sites because we'd undergone a merger. But most importantly, we wanted to involve those key stakeholders and our patient partners. So that voice was really important to us. So GPs and our patient partnership group were key players in the development of the digital tool. We were also very fortunate that we'd had a new digital EPR system called Epic. So we wanted to use that existing functionality as there was one source of truth in there, which was the date that the cancer diagnosis was given and the treatment type. So it was really important that we made good use of that. The other thing, we wanted to get some consistency across our 9 cancer sites across the 2 hospitals. So at the point of introducing this project, we had about 18 different versions of an end of treatment summary, which was really confusing for patients, especially as some patients having secondary cancers or moving between cancer sites during one episode of care. Oh, so it's not letting me move on. So very simple planning. You'll all be familiar with this. So we use the trust merger as our starting point, and we'd learnt from previous mistakes when doing IT projects. So the first thing we secured was our analyst who was going to build the tool, because that had been our stumbling block on other projects. We then set up a very diverse steering group, and we had 5 or 6 patient partners as part of that. So they had their say about how they would want it to look. That fed into a CNS working group. So they had heard the patient partners. So they started looking at how this end of treatment summary would work. So this has taken us from a very generic format. Now we were moving into a personalized format of how that would look. We wanted to digitalize it, which we did during the second phase of the project. And then we set it out across all the cancer teams on a phased implementation so that they could have their say throughout. And they made individual changes, but using the one generic template. We built in another patient feedback mechanism after the implementation. So we sent out Q&As to patients that had received the end of treatment summary so that we could find out what that felt like receiving that and how they might use it and whether it was user friendly. So that was really useful to us. We also asked GPs at the time how they found it. And then most importantly, we had a reportable function so we could see what teams were doing and how they were using it. So that was really beneficial. We also kept in mind that there was a bigger project going on across Devon to roll out EPIC. So we kept in mind that this needed to be useful for another 2 organisations coming up this year, in fact, starting in April. And that's already shown to be the case. So here is the end of treatment summary. So you can see the cancer type. Here's our one source of truth circled up here. So this gets pulled from one source of truth in the EPR system. And all the dates are automatically pulled through for colleagues. So this is really quick to fill out. And then we can be very much more specific. So we can start empowering patients with the information as it flows through. So we can tell them that some things that happen as part of their treatment are going to happen, and don't worry too much about it. We can give you these tools to work through that, but these are normal side effects of the treatment and they will pass. But the important thing are the things, are triggers, the red signs that we absolutely need to know about. And please don't wait for another appointment. Pick up the phone and tell us right away. So that was one of the most empowering things on this new digital tool. We were able to build that in. But the patient side of it is this document is addressed and is sent to them, whether digitally or via paper. We can do either, but it's addressed to them, and how they use it is up to them. We wanted it to inform their cancer care review with the GPs, but they could take it to other appointments, so they didn't have to keep going over and over their story. They could hand it over, share information as they chose about their journey. And then we built in a box as part of their feedback that they wanted some individualization of this personal end of treatment summary, and we were able to do that. So anything that came outside of the normal, we were able to do and add that in for them, which was really useful from their point of view. So the impact of the results. So from the patient's point of view, it was one source of consistent truth. So the dates and everything matched with all other communication. There was no room for any error, no admin error. We had almost 500 people that we sent it to in the first instance. And that feedback mechanism we built in, we had uniformly positive feedback. So they didn't ask for any adjustments at that stage. But what they let us know was that it validated that experience that they'd been through. They felt it was really good to see it all put down in writing, that the contact details were on the end of treatment summary. So it was very easy to know who to contact and when to contact those people. So it put them back in their own driving seat. It gave them self-autonomy, which I think is really important when we're trying to develop areas of healthcare that have supported self-management. It's a very active partnership between the healthcare professional and the patient. So that was really good. During the trial phase, our initial phase, we actually had 2 patients report back in, and we brought them back in really quickly, and we re-diagnosed a cancer. So they didn't wait for that next appointment. They were on it, and that allowed us to respond much more quickly. Some of the unintended benefits, I think, were that we saw an increased take up with our holistic needs assessment. So that's another element of personalised care and support. And that's because we had a drag and drop mechanism in the end of treatment summary that automatically pulled it from our EPR, and the clinical nurse specialist did not want to see empty boxes there. So it encouraged even better behaviours within our healthcare professionals to get that done. Our Epic is a wonderful tool, and it's got a pre-charting function. So we were able to let our cancer support workers who are Band 4s pre-chart it in preparation for our clinical nurse specialist. This reduced completion time for some of them were taking up to an hour, really down to 20 minutes of patients. So it was a massive saving for our CNS workforce, as we've been asking them to do much more higher level work, like Breaking Bad news clinics for etc. So we were able to respond to the pressures of the organisation as well at the time by bringing this in. It was reportable, so it meant we could meet our requirements with the Cancer Alliance and NHS England, because all of that was built into the background. So that was really helpful for us. And we have used it to support business cases for our CNS workforce. So we've used it in multiple ways. The patient voice was really clear throughout and has continued to be so. That the biggest one was really putting perspective on everything they've been through after a cancer diagnosis. And I think we should never underestimate the treatments are harsh, and they almost need to be told how well they've done. And this document kind of helps to do that in black and white format, because it is addressed to them and it's about them. But they really like the possible alert symptoms back. So that bit about empowerment and letting them have self-autonomy, they could say, I've been told I need to let you know about this. And that empowered them to hold conversations in a very different way. And people wanted to know what their future might look like. So really very, very useful all round. And well, are we successful? Was it sustainable? Well, it's carried on, and we've seen the end of treatment summaries going from gross to growth. So yes, it has been really good. And that's because I think we had that diverse project steering group with the configuration analysis and our patient partners and the clinical nurse specialists. So the people that were going to be developing it, the people that were going to be sending it, and the people that were receiving it. It was really important to have those 3 people in there. The sub-working groups that allowed us to personalise the document helped it even further. Being co-designed and going from a generic document to a personalised document and then individualising it for the patient was seen as a success, using our EPR and the phase of the go live, and then constantly getting that patient feedback. So throughout, the patient voice was very loud. The reporting is really good for us as an organisation, but this is now ready to go live into the other organisations that are coming on with Epic. So they don't have to reinvent a wheel. This is a drag and drop mechanism that's already gone in for another 2 trusts now across Devon. So we don't want to be reinventing wheels. None of us have got time for that. So we can share this widely at no cost. And just to let you know, we haven't been sat on our heels since last October. We're moving forward with our digital work, which I should say, as well as people being able to get this digitally, we've got paper versions for those who would rather not, who are unable. So everything has been backed up with paper versions, but we are moving forward now with something called Care Companion. So this is a digital tool doing the health and well-being section of personalised care and support. It's an education package, so we can help patients with all the knowledge that they might need at the beginning of their pathway. The beauty is, rather than them coming to clinic, being handed a pile of leaflets, they don't quite know what to look at and in what order, we can drip feed this information over days, so we can organise it for them to help them. And you can see there the end of treatment summary has been built into it already. So this almost really helps with the front end of the story to let them know one will be coming and this is what it's about and this is how you can use it. So we're increasing the empowerment for patients as they go. Thank you very much for listening. That's the end of our project. I'm just going to stop sharing.
Thanks, Maria. That's really, really brilliant. Great to hear, and an inspirational example. Maria's case study is just one of the winners from the 2025 Patient Experience Network Awards. We're going to talk more about our plans for the 2026 awards in a bit. So there'll be information there on how you can get involved and how you can submit entries into that as well. But we're going to turn now to Q&A and just take some time for questions that people have raised. We've had a few questions in the chat already. I know that a lot of people are having problems with the Q&A. We've checked the settings and we're not sure why it is, so I'm really sorry about that. But if you do have questions, drop them in the chat. Tag my colleague Nicola if you can, and we'll make sure we get to them. I'm going to start though with a question that we've had in a few forms, which is about inequalities and subgroup analysis. A few people have asked about different subgroups and how we've looked at the experiences of different communities within settings rather than just across settings, or rather what data we have to be able to look at that. And Tom, you're part of our coordination centre working with the survey data. You're probably a good person to answer this.
Yeah, thanks. As I mentioned in my response in the chat, that all of the surveys that we reference in have really detailed subgroup breakdowns available online. And the first of the two links that I've popped in that comment will take you to a page that takes you through to the results from those surveys. It's often referred to as things like national tables or something like that. But the second link that I've included there, subgroup graphs, shows the sort of thing that is available, but for the maternity survey. We also have a separate link that I'll just share in the chat now, which is the interactive dashboards for the staff survey sites. So if you did want to do that type of analysis looking at responses to the staff survey, you can do that via the interactive dashboard as well. But yeah, I do also take away the feedback. I think, yeah, possibly there is more that we can do in the future to draw out inequalities in the reports for the future iterations. Yeah.
I think that's well heard, and definitely in line with our own aspirations as well. This is the first time we've done this report, and we wanted to have a kind of helicopter view, a state of the nation of person-centered care. But a lot of the really interesting variation, as people have rightly identified, is amongst subgroups and amongst how different kinds of people experience care. So we're very, very keen to look at how we do more with that. In the meantime, as Tom said, please do use those resources. They're really, really powerful as a way of exploring people's experiences of care. I want to move on to the next question, a question that we actually sent in advance. So I'm just going to read it out. If the aim is to ensure that the patient is king, how will corridor care of patients in hospitals and waiting times in A&E be eradicated for this statement to mean anything? So, Ollie, I'm going to direct that question to you, if I may.
Thank you. So great question. And I think this is a core part of our thinking around this as well, is that obviously the statement to make the patient king is great in itself. We need to see that translate into reality. And we also need to be aware of the fact that there are a lot of pressures in the system currently that mean people are seeing suboptimal experiences of care. So we need to differentiate between what is an interim solution to current challenges in the system, and then moving towards a series of kind of excellence in care and how that should look in the future. I know that from conversations with various people that there's a lot of concern around corridor waits, particularly in A&E. And I think there's a risk, of course, that this could become, as people, move to put solutions in place in the short term, there is a risk that they become longer term solutions as a kind of sticking plaster that ends up staying in place. So it's really important that we avoid that as well, because we don't want to end up in a situation where that becomes the norm. So it's a really great question, and I think it's a really great question for the department in itself, in terms of how person-centered care and patient experience are really centered within the reformed Department of Health and Social Care, with the changes that are currently happening there at the centre, and thinking about how we can make sure that person-centered care and patient experience are really built into everything that the department does going forward, instead of it potentially being sidelined if it's not built into the system in the correct way.
Thanks, Ollie. That's really, really helpful. I'm just come to Maria next, because there's a couple of comments for you in the chat, Maria. I want to make sure you've seen them. First of all, a very appreciative comment from someone in Portsmouth, from Kate Bentley, who'd like to get in contact. So I'll leave you to respond to that directly. But there's also a question underneath that from Diane Smelt, asking about your experiences with Epic, as their institution have recently procured the same system.
So Epic was given to us at the beginning of COVID in 2020. It was quite a shock when it came into the organisation, because you suddenly go paperless. So as healthcare professionals, you have to go paperless. But I think you'd be hard pushed to find anybody that would let you take it away from them now. So it takes some getting used to. I will say it's not all quite intuitive. You have to learn some of what's going on within the build. It was better for inpatients and outpatients, definitely. And I think that was where it originally came from. It wasn't really built for cancer services, and we have had to do all the builds ourselves to make that work for us. So that felt like quite a journey initially. But it's becoming some benefits to it now, I would say, because actually we've been able to shape it and make it look and work how we want it to do, with our patients in the background. So it takes a while, but we absolutely love it down here in Exeter, and we're building on those strengths now and moving it forward.
Thanks, Maria. That's really helpful, and thank you again for sharing. I'm going to come to Molly next, if that's okay. There's a question in the chat around how people responding to the surveys define quality. We've obviously talked about the kind of overall measures from the different settings and the variation in those, but yeah, how do people who report define quality, and how does that align with the PICA principles? Molly.
Yeah, I think that's a great question. And I think a really important point is to acknowledge, like, I know Tom's touched on this, that each of these are an independent study that have their own data sets. And each of these surveys have gone through rigorous testing before they're launched, where we cog test. So we interview people, we go through the survey, and we have those conversations. Now, in terms of the questions that we ask in the survey, we ask them specifically to answer based on kind of their experiences when they're talking about their overall experience of care, rather than the outcomes they've achieved. But also, one thing we found when we're doing cog testing is when we're going through and we're completing the survey, they're completing the survey on the phone to us, we ask them around what are they thinking about when they're answering these questions. And that gives us a really a deep insight into kind of what people think about when they answer that question. And it really does align with the principles that we've developed. It isn't just a kind of a clinical safety and effectiveness kind of point that they say. When they talk about quality, they talk about the kind of the treatment they've had, the alignment they've had, that the care that they're having access to aligns with their needs, it aligns with their preferences, it gives them options, it gives them choices, it's compassionate and empathetic. So yeah, I would say that it does align with what we've pulled together with the PICA principles. And as I said earlier, the PICA principles have been developed and refined through research with patients. So yeah, there is a close alignment.
Thank you very much, Molly. I'm going to move on to another question, which is in the chat around training for person-centered care. I've just misplaced the question. Trying to locate it. Jean McQueen had asked about the recommendations for training NHS staff in person-centered care, whether we have any detail on the kind of training staff already receive, where the gaps might be, and I guess what the benefits of this would be. Ollie, this is one of our recommendations, so if you'd be happy to answer, please.
Yeah, of course. Thank you. So this recommendation is one that we have put out there before. So we had a manifesto that we published ahead of the general election in the UK in 2024. And there we called for a requirement for all staff to be trained in person-centered care, including shared decision-making and support for personalised self-management. And we'd envisioned this being not just for clinical-facing staff, but also for non-clinical staff, so they have a good understanding of how person-centered care operates and what its priorities should be. In terms of the training that's already available to NHS staff, so there is an organisation called the Personalised Care Institute that you may or may not be familiar with, and they offer training in personalised care. It was set up as part of NHS England, or as a sponsored by NHS England initially, and there was some funding provided with that. There is now a model where you can sign up to PCI Plus, it's called, and you can access those courses in their full detail. So I can put a link to that in the chat if you're interested to find out more about that. Obviously, there are other conversations around mandatory trainings that are happening in the NHS, and that was obviously part of the 10-year plan and this move towards kind of removing training that's seen as kind of unnecessary, I guess is the wording that in some cases has come forward. So that's something that we want to keep an eye on, because obviously we'd be concerned if kind of training is being stripped away from people when it could be beneficial to getting these concepts more broadly into the healthcare service.
Thanks, Ollie. There are a couple of questions that are related around continuity and coordination of care. So Carol McHugh asked about how person-centered care can address the needs of people who require ongoing support in the community rather than resorting to residential homes. Roxanne Levy asked about the impact of people with comorbidities when they're being shifted across services and departments. I guess the overarching theme is how the service manage people with complex needs who are perhaps moving between different settings rather than having a very simple transactional episode in an A&E department and then going home. I don't know if any of my colleagues would be happy to say a few words about what we found about continuity in the survey or surveys and in the report.
So in terms of continuity, so it's an interesting one, because obviously a lot of the surveys are in particular silos around particular areas of care. So it can be challenging to kind of pull across that continuity of care for different comorbidities or multiple conditions. But it's a really interesting point, and obviously as we move towards a system that is more integrated, that'll be something that comes forward in the future. We know that NHS England, for example, are looking at kind of how they look at the future of patient experience measurement and design. So that's something that I'm sure will factor as part of this. And I think the other thing to mention as well is obviously we're moving into a world where people are obviously living longer with more multiple conditions. So it's something that needs to be considered as part of that as well.
Thank you, Ollie. That's really helpful. I'm conscious of time. I'm sure many people will have other appointments to get to or simply lunch to enjoy. So I don't want to keep us past 12 o'clock. What I'm going to do now is just start to wrap up. If there are things that you have wanted to ask, haven't had the opportunity to get answers, please do let us know in the chat. We'll follow up with you after the meeting, and we're very happy to kind of maintain a dialogue with people. So that's certainly an option. Nicola, would you mind bringing the slides back up for me, please? Thank you. So I'm going to just try to get to the right page. Okay, so just to wrap us up then in the final couple of minutes, first of all, a really, really big thank you to everyone who's taken part in the session today. Thank you for being here. I know time is precious. I'm really, really glad that you've chosen to spend some of your morning with us, and I hope you found it to be useful, informative, thought-provoking. I hope it's raised questions. I want to say a little bit about our offer and the further resources that we can provide. So we, as a research organisation, issue regular reports about our work and about the field of person-centred care and patient experience. I want to highlight a couple of recent examples that I think might be of interest to people attending. First of all, we've recently published a study looking at the NHS Friends and Family Test and how that can evolve to be fit for the future. That's a really interesting one that draws on the literature, our research experience, and on stakeholder views about the FFT, which is controversial at times, but very, very widely used. We've also published a document called Learning from the Best, Celebrating Patient Experience Innovations to Help Deliver the 10-Year Plan, which maps winners from our recent PICA Experience Network Awards to the priorities from the 10-year plan. Whether or not you're in England, in the UK, working towards the 10-year plan, that's a really useful document just in terms of highlighting some of the winners from Penn and describing what they mean for policy. We also have the full book of best practice from Penn, which is just an absolute goldmine, a treasure trove of best practice and inspirational examples. So please do look those up. We also offer a learning and development program. So that includes courses, training and support on a range of subjects related to person-centeredness, including EBCD or experience-based co-design, co-production, effective facilitation, and measurement for improvement. So if you are involved in collecting, using, improving patient experience, we can help with that. Please do get in touch. That can be online, in person, in-house, whatever you need. We also have free improvement toolkits, and we run an EBCD community of practice that you're able to join. I particularly want to flag the upcoming PICA Experience Network Awards for 2026. This is our flagship event that celebrates best practice in health and social care around person-centeredness. We are planning to open submissions in March, so there'll be an opportunity for people to enter then. That runs for 3 months until the end of June. We'll then be shortlisting, and we have a live awards ceremony planned in Birmingham on the 1st of October. That is always a really brilliant event. It's always really well attended. It's a great opportunity to meet like-minded people, to network, to be inspired, and to be proud of what you've done. So if you've done some great work around patient experience and person-centered care, please look into the Penn Awards. Please consider entering. We'd love to have you there. But mindful of time, I think that's really all I want to say today. Thank you again for being here and taking part. I want to say a big thank you to my colleagues, Nicola behind the scenes for making sure things have been running smoothly and for supporting with queries. Ollie, Molly and Tom for presenting our findings and for helping to organise today, and to Maria for very, very kindly joining us and showcasing some best practice and kindly answering a question based on that as well. Thank you all very much for your time. I hope you all have a wonderful day. As I said at the start, we'll be sharing slides via email after the meeting, so you'll have access to those. We'll also be sharing a recording once we've had a chance to edit that and put it online. So that'll be available if you want to share with colleagues in your organisations. And if you do have any questions, you can reach us via the email address on screen, publicaffairs@picaeurope.ac.uk. We're genuinely very happy to chat. We're very happy to follow up on any questions that you might have. And we look forward to continuing the conversation. But that's all for now. Thank you very, very much for being here. Take care. Have a lovely day.